I think the general line of demarcation for IO combinations that we're exploring right now are anti-angiogenic combinations with immune checkpoint inhibitors, so meaning the atezolizumab plus bevacizumab regimen, which has already shown positive results in the phase 3 IMbrave 150 trial, but also the TKI combinations of tyrosine kinase inhibitor combinations of atezolizumab plus cabozantinib, which is the COSMIC 312 trial, and lenvatinib plus pembrolizumab, which is the LEAP 002 trial. So those three trials are all immune checkpoint inhibitor plus anti-angiogenic agent. Now, we also have, again, returning to the theme of Himalaya, the immune checkpoint inhibitor combination trials of not only Himalaya of the combination building upon Study 22 data, but also nivolumab plus ipilimumab in the Checkmate 9DW trial. And so all five of these are pivotal, or excuse me, atezolizumab plus bevacizumab is already completed, of course, but there are these four other combinations now in rapid succession with phase 3 data on the horizon. Of course, it'll be very difficult if, hopefully more than one of these studies will be positive, but that will obviously lead to challenges to clinicians and the guidelines to assimilate and rank in order. I think there are some really important considerations both in the efficacy space as well as in the safety profiles of these drugs. And so, of course, individual patients' comorbidity profile and toxicity risk will be a primary decision maker, particularly for anti-angiogenic regimens that have a higher risk of bleeding. This is a population with portal hypertension, which means elevated pressures in the GI tract and risk of GI bleeding, whether it's in the stomach or in the esophagus. And so particularly, say, for atezolizumab plus bevacizumab, patients really need to have had an endoscopy to screen for varices, and anyone who has high risk for bleeding or history of bleeding really is not appropriate from the data we have for that regimen. And so to return to your question, patients like that, which are not infrequent in HCC, would really perhaps be better served by an immune checkpoint inhibitor combination should one of those reach its primary endpoints in the phase 3 context. So I think that's an important point of discrimination on the toxicity and efficacy or toxicity front. With respect to efficacy, I think it's very interesting to look at these regimens for the question of whether we are truly achieving an immune response versus the additive sum of parts of the two components. And so we know that immune checkpoint inhibitors have an inherent response rate, but we also know that drugs like bevacizumab, lenvatinib, and cabozantinib themselves can achieve disease control. And so I think another distinguishing factor between dual immune checkpoint inhibitor regimens versus the anti-angiogenic combinations is whether we are achieving an additive effect of two active drugs independently, just simply added together, or whether we are truly converting patients to immune responses through the immune combination, say, of a checkpoint inhibitor regimen. And so those are difficult questions to ask with clinical data, but some of the data that will, I think, emerge over time as we have longer follow-up from these studies, like duration of response and the patterns of medians, whether we're seeing sort of a bimodal duration of response, some patients with shorter duration, some longer, versus all of them really long, compatible with what we expect from a deep, durable immune checkpoint inhibitor response. Those are the questions I think we'll have to glean from the data as we get more follow-up time and more nuances to the data.